You kind of think that your estrogen is always much higher than your testosterone, but actually it's the other way around. So our testosterone levels are lovely and high throughout our whole reproductive life. And if you were to change them all, both into the same unit and you put them on a graph, you'd clearly be able to see then our testosterone ranges between 3 times to 10 times higher than our estradiol throughout our reproductive life. And it starts to fall then often in our late 20s or our 30s. And it just does this gradual decline, like you might see in a man in his 70s.
Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Bird, pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. So get cozy, hit that play button, and let's rewrite the narrative around this remarkable stage from being something to dread into a beautiful transition. So I'm very delighted to have on the podcast today, Dr. Aoife O'Sullivan. She is a medical doctor down in Oregon, a little bit south of me. She has a telehealth practice through Heather Hirsch Collaborative. She has her own company, Portland Menopause Doc, LLC. And she's also not only a menopause specialist, but she's had many, many years of traditional medical experience and education. And I'm excited to get into talking with her about what menopause care looks like for women right now, what we can see in the future, what our hopes and dreams are for midlife women, and also how telehealth medicine works in her practice. So thank you so much for joining me today. I'm excited to have this chat with you.
Oh, it was very kind of you to invite me on. Thanks so much.
So I've been following you on social media. I kind of feel like, this is one of those niches where everyone supports everyone because there's enough patients, there's enough of an audience around that there's room for everyone. And so I feel like everyone that's in this space that I've been seeing has been sharing each other's posts and collaborating on work and joining each other for talks. And it's been such a collaborative environment that I'm so excited when I get on and I see all this positive energy toward the menopause and midlife healthcare movement.
It feels really good. That's pretty much what I have experienced as well. Just a huge group of women lifting each other up. And it's such a really nice space to be in at the moment.
So not only are you a healthcare practitioner, but you also give talks to resident communities, other medical professionals. You're going to be talking with other collaborative physicians and other care providers at the Menopause Society in Chicago. So tell me a little bit about what you do outside of just taking care of patients for the menopause community.
So yeah, something I have gotten into, which I really enjoy and was kind of unexpected for me, was teaching. So there are quite a few residencies around Portland, family medicine residencies in particular. And I remember the first talk I gave, I wasn't 100% sure how it was going to go down. I kind of had this thought that maybe, people would be standing up from their chairs and waving papers in my face saying, no, HRT causes breast cancer. And I would have to fight my corner. And it was so the opposite of what I actually experienced. The doctors and clinicians that I spoke to that first time were just starving for that information. They wanted it so badly. They felt angry that had been withheld for all their medical training. I think most of us going through medical training would say that we were taught that women of a certain age were kind of moany and complainy and weren't happy with their lives and developed all these psychosomatic symptoms, meaning kind of in your head. And the treatment would be with anxiety medications or antidepressants and maybe some therapy. And I think that was kind of an underlying belief, even if it wasn't kind of spoken out loud through all our training. And it's really quite eye-opening then once you learn how important those neuroendocrine hormones are, estrogen, progesterone, testosterone, how, there's receptors on almost every cell in our body for those hormones. And it's not just about your period starting and your period stopping and having babies. It's so much more than that. And so it was really such a delight to see other doctors want that information and made me really hopeful. And so that's a big part of what I do now, teach, and then also to groups of women in the community and also at workplaces. We talk about menopause in the workplace. And so that's been something I was unexpected, but I really enjoy.
Well, I'm sure, in speaking for a lot of people in healthcare, you don't go into it for the fame and glory. You go into it to help people. And I'm sure it's very frustrating for these clinicians to have their patients come back after 3 or 6 months and they're still frustrated and they're still not feeling better because the antidepressant or the breath work or the therapy that they said they should be, they prescribe, when they see that that's not what's effective for them, they have to be beating their heads against a wall as well. So I'm sure they're intrigued and interested to learn. I remember in pharmacy school, I graduated in '04. So I was like, I saw both sides of the WHI study, and it was amazing just that, the pills are getting dust on the shelves and nobody's prescribing them anymore. And we barely talked about it in pharmacy. We might have a case in therapeutics where there was some hormones on the list of meds, but we never discussed it as a disease state. How did you feel in your training?
Yeah, so I know kind of like a common theme at the moment is that the WHI destroyed education, doctors being educated. And I started med school in 95 or 96, and I didn't get any training on menopause. And I left medical school in 2001, which was the year before the WHI, and did a 3-year residency in Ireland, of family medicine, and then did another 3-year residency in family medicine at the University of Maryland, and didn't get any training on women's hormones or midlife care. And I remember years into residency in clinic, and I had a patient come in and she asked for a refill on her estrogen patch. And I had to go find my supervisor to say, what is this thing? And what do I do? And how do I refill it? I couldn't. That's after nearly 12 years of medical training. That's
Yeah.
absolutely disgraceful.
Yeah, and that's incredible, but that's pretty much what I hear from most physicians and other care providers around our age, is that there just wasn't the education. And, there's also, I remember my grandmother being a nurse eons ago, and she would wear patches. And I remember it being a joke in the family that whenever she would get temperamental or moody or a little crazy, there would be this like, oh, do you need to go change your patch kind of joke. And so then it's almost where women don't want to admit that they need this. They don't want to talk about what prescriptions could benefit them as well. There's this stigma around menopause and the mad woman syndrome.
Yeah, even I'm laughing at you because even my husband occasionally will be like, honey, has your patch fallen off by any chance? I'm like, what? Oh yeah, it has fallen off. You're right. That's why I'm so cranky and overwhelmed. It doesn't usually fall off. They're usually very good, but sometimes they do.
Yeah, but we should also have some grace around that a little bit as well. I mean, we can't help it sometimes.
I know, absolutely. Yeah, it just goes to show you, how much of a massive effect those hormones have. What boggles my mind is that as clinicians, we have been so easily just, like they shook a shiny little object over to the side and we ignore all these things that our brains are picking up on, our eyes are picking up on, our ears are picking up on. Our patients are saying to us, I had these same symptoms after I delivered my baby. I had this, when I was pregnant, I felt amazing. And now in this period of my life, I feel so bad. Like how they've been able to do that, to get us to ignore the signs and symptoms that patients are telling us about, and for us to just believe, not to look into it any further and be curious. It boggles my mind.
Yeah, I actually have a light bulb. I remember I was on bed rest and I was given progesterone injections just to help, calm everything down in my system so I wasn't going to have a baby early. And I developed like Elvis sideburns and I had hair growing in places that it should not. And, and I I never put two and two together with like, are my hormones out of whack? Am I pumping myself full of different hormones? And then you get the hair loss when after you have the glowing hair when you're pregnant, and then you're not pregnant anymore and it all falls out. Those are all things that you never think about. And then you go through it again in menopause and you're
Yes.
not putting it together that this is all hormone related.
Yes. And why can a doctor know that there's a condition called premenstrual syndrome, or dysphoric disorder, and know that that's very connected to a woman's hormones and it causes anxiety, depression, overwhelm, lack of sleep. And yet when a woman comes in during perimenopause and tells her doctor she has those symptoms, we say, oh, you need some therapy. You're overwhelmed. You need an anxiety medication, an antidepressant. It's just really astonishing how we can't join the dots.
Yeah, I feel like that's becoming a little bit more, there's more of a niche in medicine that there are providers that are becoming menopause specialists.
Mm-hmm.
And so that's a plus. We still have a lot of doctors who are very hesitant to do anything with hormones. They're very hesitant to change the way they're practicing medicine, even if they've been practicing it the same way for a very, very long time. So what are you seeing in the patient population when they come to you and they say, that's it, my OB-GYN isn't helping me, my primary care physician doesn't know what they're talking about? Like, what do you see coming from your patient population?
I see some big things coming up all the time. So the number one thing I'll see is that a patient has been to her OBGYN. For some reason, the OBGYNs cling on to this more than I would say internists and family med docs. The change in periods. So they'll say they went to see their OBGYN and they told them all about their perimenopause symptoms, and their doctor agreed, yes, this sounds like perimenopause, but your periods haven't changed. And so it's not perimenopause. I mean, that's what I'm talking about, right? How, if someone came in and said, I'm having severe chest pain. It's radiating up my neck, down my left arm. I feel like there's an elephant sitting on my chest. And I do a tracing of the heart and it looks pretty normal. I'm still really suspicious. I'm not going to let that person go home. I'm going to send them to the emergency room because I feel like I'm missing something, Even though that piece of paper is telling me everything is okay, I, as a doctor, have a brain and logic and cop on. And I know that doesn't make sense. And yet a woman can go to her doctor and give them all the right information. And because something they've been told to believe in isn't part of that description, then they write that patient off. And there's never really any, let's, in 3 months we'll do this, or 6 months we'll do that. It's like, well, there you go. It's not perimenopause. See ya. So that's really hard for women. There was information collected years ago as part of the SWAN study, and they put together this lovely diagram which helps you see when a woman is going through the menopause transition. And I really think instead of that being used as a helpful guide, it's become almost weaponized against women, because that's where they pull that information from. It specifically says, the first thing that's going to happen is your periods will change. There's just nothing else like that in medicine. We never say, if you're having a heart attack, the very first thing that will happen is you'll get short of breath. No, you might have nausea, or you might get clammy, or you might feel feeling of impending doom. There's just nothing else where we say, if you don't have this one thing, everything else means nothing. It's insane. And I see it all the time. It makes me so frustrated. And these women are left then, to just keep looking. It's exhausting. And if you make an appointment to see a doctor now, you could be waiting 6 or 9 months to get your initial appointment. And then you come out of it with that answer. It's so disappointing. And then the other big thing that I see as well is blood work. We all know going through perimenopause, your hormones are all over the place. They are up 1 minute and through the floor the next. And yet your doctor will say, we checked your hormones. They're all normal. You're not in perimenopause. And, The doctor doesn't think of it as gaslighting because they don't have the information to draw from. They don't have the training to connect those dots. But to the patient, it feels like gaslighting, right? I'm looking at this big brown melanoma that's growing on my hand, and I go to the doctor and they say, no, there's nothing there. It's okay. What do you do? Your
And
skin looks
yeah,
beautiful.
and you waited so long for this
Yes.
conversation. Yeah, my personal experience, it took me a year and a half of fighting like heck with my OB-GYN to finally find a different practitioner in a different clinic altogether, because I did the blood work, and I understand the need to rule out issues with the thyroid and other things, and you want blood work, you want to know what your cholesterol levels are, and you want to know what your hemoglobin A1C is. I understand all that's important. But I remember getting the call back, and it wasn't even my physician. I think it was their medical assistant that called back, and she's like, "Well, I just got your blood work back and all your hormones are normal. You're not in menopause." And I said, "I never said I was in menopause. Nobody ever said I was in menopause. I had a period 3 weeks ago." Like, I know I'm not in menopause, but I can't sleep. I'm waking up soaking wet. I have 3 a.m. every morning. I'm wide awake, terrified of things that don't make sense, and my periods are all over the place. They're heavier. Sometimes they'll be 15 days away, and sometimes they'll be 45 days away. And I'm explaining all this to her, and she's like, "Well, I can give you some trazodone for your sleep and see where it goes." And I was like, "Oh, that's it. I'm out." I mean, I just didn't know how else to bang my head against a wall, because I've done the research. I know what I'm looking at. I have some medical background, and I still can't get through that wall at a traditional OB-GYN's office. So luckily we have a menopause care clinic in town. I've told you that I need to stop referring people to them because they're running out of space in their clinic. But it's unfortunate that it's linked to either your primary care physician or an OB-GYN when they're both bogged down with too many things also. I mean, menopause is such a niche, but it's so expansive, the symptoms, the treatments, how long it can take up to 10 years before you're in menopause. And so it really does need a specialization all its own, because the healthcare providers that we're looking for this they're not trained, but they also don't have the time.
You can't give an OBGYN or an internist or family med doc 15-minute visit or a 10-minute visit and then expect them to do that first appointment for menopause is so detailed. You need so much history. There are so many symptoms to ask about. And you're also at the same time trying to figure out, is this perimenopause or is this something else? Am I missing something? So there's 100 different things going through your head. And it takes so much time. And there's just no way in a normal practice for most clinicians that it can be done. So I honestly when I talk at residencies and such, I do try to teach how to start a woman on some basic hormones while you're getting blood work and you're working things up. And because that in itself gives you so much information. If you start somebody on a little dose of estradiol, a little dose of progesterone at nighttime, and they come back in a few weeks and they say nothing's changed, nothing, not any improvement, then you're definitely thinking, yeah, I'm missing something here, But if they come back and they say, oh my God, I'm getting a full night's sleep, I can think, I'm able to function, I don't have to lie on the couch all day, I have energy, you're barking up the right tree. And now it might take a little more finesse, because every woman is so different and it's so nuanced. But I'd say 50% of the time you would get away with just doing some really basic hormone treatment like that. And then maybe 50% of the time, or maybe a bit less, you might need some specialist help. So I do think if we were trained in it, at least we could use it even as a test of cure type of thing, to see if it works while you're referring somebody on to a specialist.
Yeah, that's a great starting point. And that makes a
Yeah.
lot of sense, especially if they can't be trained in every single aspect of it. But here's your starting point, here's your platform, and then you can jump off of that. And in talking with you about hormones specifically, you know, how do you deal with women who come to you expecting hormones? You give them a prescription, and like we were talking about, it may not be the right fit for every woman, or the form of hormones that they've been given may not be right for them? How do you go about handling that?
Yeah. So again, like we said, it's really nuanced. So you can kind of start with the basics. So I'd normally go through with my patient what's available, what's a good option for them. I explain the differences between using estrogen by mouth or using it through the skin. If they want to use it through the skin, the different options that we have, because some you would only have to use once a week, some you would use twice a week, and some you would use every day. And some women are like, oh, yeah, if I don't do it every day, I won't remember it twice a week. And other women are like, oh, God, no, twice a week is perfect, or once a week, even. And so you kind of get people started by finding out some basic information about them, like that, even kind of personality type, and then get them up and running and then follow up and see what's happening. What kind of percentage improvement have they had in their symptoms? And any side effects that they're having. And then you all make any alterations based on that information. That's really helpful. There's a menopause questionnaire that I love. They're all based on the Green Climacteric Scale. And that's a series of, I think, 23 questions. And you can score 0, 1, 2, or 3 for each one. So I think a total of 69. And I usually get my patients to do that before I see them. And then I'll do it again for each appointment. And even when someone comes back and goes, oh, I feel much better. Yes, this is improved and this is improved. You're thinking, yeah, that's good. That's good. So things have improved. But if you actually get them to fill out the form, it could be a change from 55 to 20, which is a massive change, and people are always really surprised when they look at that paper and go, oh my God, I didn't remember how bad things were.
Yeah. Well, and like you said earlier, there's estrogen receptors all over our bodies. And I've heard from so many women that once they do start supplementing estrogen back in, they never realized what else was included in their list of symptoms outside of just the standard hot flash, weight gain, night sweats, that there's so many things that it quote unquote can fix when you're deciding to supplement that back in.
It's so interesting. Even just myself, I had this itch on my right shoulder blade for probably 8 years. Just every day, I would ask my husband, can you please give it a good scratch? It would drive me crazy, especially going to bed at nighttime. And then when I started my hormone treatment, it disappeared. I'd had it every day for 8 years. And, things like cracking in your knees and that crepitus disappeared. It's so interesting. It's not just that we have, estrogen receptors on every cell. They're there for a reason. They're not just there. We don't just happen to have them. They have a job to do. And when those receptors are empty, we get some serious symptoms and signs.
Yeah, I put up a thread a couple days ago. I'm new to threads, still figuring it out, but I did put a thread up asking women over 40 if there was a symptom that they've had that was related to perimenopause that they didn't recognize was perimenopause until they either learned it from a doctor or a friend or, after going on hormones, it went away. And itchy ears, achy joints, frozen shoulder, those were all things that
Yes.
just kept coming up and up. And then there were women that were like, I'm just here for the knowledge. I'm learning a lot from this thread. And it's so crazy, the dry eyes. I mean, I've never had seasonal allergies, and then all of a sudden that was something that plagued me. And it's just crazy how many things we as women tolerate as being
Yeah.
acceptable that
Yeah.
we can actually correct.
And it really affects your immune system. And that can be at the level of the white blood cells. It can be because you're not sleeping, things like that. And women will often say that any virus going, they catch it. They're always sick now. They never used to be sick. So it's so true. The itchy ears, oh my gosh, so many women have that. And tinnitus is another one.
Yeah, burning
Yeah.
tongue. I had someone message me and
Burning
say,
tongue.
"Yeah,
Oh my
is burning
God, it's
tongue a
so
sign of?"
bad.
It's crazy. I never would have thought it. And then I had women just keep coming to me saying, "Got this burning tongue thing. Is this related?"
And unfortunately, that's really hard to help because, you can start someone on HRT and their 90% of their symptoms might disappear, but often the burning tongue does not respond very well, unfortunately, but does seem to be connected to those hormones. So you
That
would wonder, why doesn't it respond better,
Yeah, that's so interesting. And maybe it's one of those things we'll find out in the next few years as they start doing
Hopefully.
more research on women's health.
Are you a woman over 40 feeling like a stranger in your own body? Introducing the Women Mastering Midlife community. Hi, I'm Victoria, a pharmacist turned women's health coach. I've been where you are, and I know the frustration of navigating perimenopause alone. Imagine having expert guidance on managing symptoms, a judgment-free space to connect with other women, research-backed resources at your fingertips, and personalized support to thrive in midlife. Our community combines clinical expertise with holistic approaches, giving you the best of both worlds. No more confusion, no more feeling isolated. For less than $1 a day, you'll have access to a resource library, community chat for support, on-demand coaching, and much more. Don't let another day go by feeling lost in your midlife journey. Join the waitlist for Women Mastering Midlife community coming in the fall. Become a founding member at our special introductory rate offered only for the first enrollment period.
One of the things that is still kind of a touchy subject with a lot of providers, or I guess with the FDA considering it a controlled substance, but testosterone. So can we talk a little bit about testosterone and how it is actually a female hormone as well?
Oh my goodness. Yeah. So our ovaries pump out tons of testosterone, as do our adrenal glands every day. And, interestingly, here in America, we measure testosterone in one type of unit and we measure estrogen in another type of unit. So if you were to try and plot them on a graph, you really couldn't. But if you were to look at numbers, your estrogen might look, like 300 and your testosterone might say 30. So you kind of think that your estrogen is always much higher than your testosterone, but actually it's the other way around. So our testosterone levels are lovely and high throughout our whole reproductive life. And if you were to change them all both into the same unit and you put them on a graph, you'd clearly be able to see then our testosterone ranges between 3 times to 10 times higher than our estradiol throughout our reproductive life. And it starts to fall then often in our late 20s or our 30s. And it just does this gradual decline, like you might see in a man in his 70s and 80s.
Wow.
Yeah. And so, that does a gradual decline, which is different to the estrogen, which kind of tanks some days and is sky high the other days and just has you all over the place. And the testosterone seems to be very important for our bones and our muscle. So really the key to longevity appears to be, how much muscle you have. It burns so much glucose, it needs cholesterol to make its cell membrane. It's metabolically active. And so the more muscle you have on board probably affects your longevity moving forward. And when we start to lose our testosterone and our estrogen as we go through the perimenopause and menopause, we start to lose our muscle mass. And even if we are weight training, it's much harder to build muscle than it was back in our 20s and 30s. So it has massive effects on us. Our brain can make testosterone. And, if you were to look at the production of our steroid hormones, they all come from cholesterol. And all our estradiol pretty much comes from testosterone. So for us to have been taught in our training that testosterone is a male hormone is just absolutely laughable and shows how unimportant women have been in medicine, in training and in healthcare.
Oh yeah. And the research, it isn't there. And I know, there's a lot of issue that I've seen where the doctor will prescribe testosterone replacement for a woman, and then the pharmacy won't fill it because the dose is incorrect, or because it is considered a controlled substance by the FDA. They won't allow more than a 30-day supply of it at a time. But then the way that it comes in a packaging of gel for male patients, then you would need a tiny microscopic dose of that, and one box would last months and months and months, and the pharmacy won't break a pot. But it feels like there's this constant headbutting for women to receive the hormone care that they want and need. And until they produce a product that is available for women, that is mass marketed, mass approved, and produced by by our regulated bodies that be, what can women do if they feel like testosterone is something that is slipping for them?
Well, there is a kind of FDA product approved over in Australia, and you can get it in the UK as well, called Androfem. And it's about the 10th of the dose of, we use about a 10th of what we would normally give a man each day. So if you are a woman or a clinician and you're thinking about testosterone, how I do it in my practice is I see some patients and I can clearly see they're not too bad estrogen, progesterone wise, but their symptoms or signs are maybe well connected to their testosterone. And so I'll go straight to testosterone. But in general, how I use it is I'll get my patient feeling pretty much back to themselves, estrogen and progesterone. We'll find a right dose for them, no side effects, till they're feeling good as we can get them. And often some women will say, I still have X, Y, or Z. And often they will be low libido, poor stamina in the gym, especially, unable to keep or build muscle, and some brain symptoms like word finding, focus, concentration, memory. So those women, and we're all so different. So some women don't have any need for extra testosterone. And then there's a certain group of women who, for them, it's that little missing piece of the puzzle. And so we have some options for prescribing. So, theoretically, you could prescribe the men's testosterone. You're probably not going to get insurance to cover it. So the patient usually has to pay out of pocket. So we use a good RX coupon. And, you have to use a 10th of the male dose. And often, even though I write on my prescription, please do not dispense the packets or sachets, they will dispense the packets or sachets instead of ordering the tubes, little tubes that come with a top that the patient could screw back on. And, they call it a gel, but if you get one of those sachets, it's a liquid. I mean, there's no way you can get a pea-size amount out of that thing. It just goes everywhere. And then you can't get it closed because it's still squirting out. It's awful. So sometimes my patients will actually get the tube with the cap, and then you can use a pea-size amount. You apply it to your thigh or your calf once a day, and that's about 5 milligrams of testosterone. And after about 6 weeks of being on that, I would check some blood work to see what my patient's levels are, because I'd normally keep a woman in what's a normal range for a female, we think is probably like between 40 and 80-ish. Men are usually up in the 2, 3, 4, 500s, up to 1,000. You find that some women end up, because their medical doctors don't know this information, they end up being funneled towards practitioners like chiropractors and naturopaths. And there can be a good bit of pellet use in that area. And the pellets, unfortunately, you're talking about stuff that's not FDA approved. And there have been studies done on pellets, and this, I'm sure, but where they're supposed to become inactive after 3 months, say, and 2 years down the road, they're still giving off testosterone. And others that burn out after a couple of weeks. You're not 100% sure how much is being released each day. It doesn't seem to be a steady state. So I'll often see women who have had pellets whose levels are very, very high. And some women, even their voice has dropped. Or you can develop a thing called clitoromegaly, which is where you get enlargement of the clitoris. And unfortunately, with the voice deepening and the clitoromegaly, those two things are not really reversible. So when you use testosterone transdermally through the skin, like I would normally do, if you stop your testosterone that day, the next day it's dramatically lower. And so you don't run into problems like that. And I would check labs at 6 weeks of treatment, 3 months, 6 months, 9 months, a year, and then every 6 months probably, just to make sure everything is staying nice and normal. Some women, Dr. Louise Newson is in Menopause in England, and she describes women's skin. Everyone has different skin. Some of us have skin that's like linoleum, like things just slide off it. They don't get well absorbed. And other women have skin that's like a clay pot. It just absorbs everything so well. And you never know which woman your patient is going to be. And then for a lot of the time, I give up on trying to get the men's testosterone from the pharmacies. The pharmacists in general give my patients a hard time. It's also very embarrassing. They'll often ask questions like, are you transitioning? Are you transgender? And, there's a line of people standing behind you, and people get really embarrassed. I don't want anyone to know my medical history or what medications I'm on. It's just atrocious that they would do that, but they do. And so often I will go to compounding pharmacies. We're lucky in Portland, we have a couple of really good ones, and the pharmacists are wonderful, and they'll get on the phone with you and help you. And so I would often compound a testosterone cream for my patient, but it's probably going to cost about $80 for a 2 to 3 month supply. Whereas if everything worked as it should with the normal men's testum, you could probably get a year's supply for $100. So definitely a price difference, but also it comes with, the compounded cream comes with that sense of privacy and
Yeah. And I've seen comments from women who have been patients at a pharmacy that the pharmacist was very, very dismissive or rude or embarrassing. And it's unfortunate. I think, I have licenses in a few states as a pharmacist, and we have all these requirements. We have in one state, I had to do 8 hours of HIV/AIDS training. I had to do, LGBTQ plus training, and I had to do end of life care,
sure.
Oh yeah, the opioids. Yes. And every year I have to do HIPAA training, Medicare Part B training. And so there's all these things required for us to renew our licenses. And it would be great if there would be a continuing education credit. It could just be an hour of, this is the basics. This is what the Menopause Society guidelines are. This is what you'll see in your pharmacy. Maybe even some sensitivity training could come in handy. And, when I was younger, I was very judged. I will be the first to say there are things I would take back about my beginning practice as a pharmacist when I was younger. And we were by a pain clinic, and I just, after having a back injury, I'll never look at the way I was toward patients with back pain the same again. And so I think a lot of it comes from just experience. And there are female pharmacists who have gone through, who are menopause, like we're in the transition right now, and just the compassion that shifts. But I think that unless you're educated across the gambit, so not just the doctors, but also the pharmacists, in what kind of care we have available these days, and the standards of care and the expectations on a pharmacist, I think, unfortunately, you're going to have to go to a compounding pharmacy. And that might also be why patients are leaning toward pellet therapy as well, is that we're making it harder and harder for them to get the care they need. And I know women, I have friends who are on pellets, and they swear by them and they think that they're amazing, but I don't think they're very well versed on the adverse effects of them. And once they're placed, it's 3 months before you can't remove them. And so it can last up to 3 months. Yeah. So that's just, it makes me nervous.
Yeah, me too. I don't do pellets. Yeah. But I see a lot of patients who have done pellets and regret it. But I also understand why women go that route, because they are looking for someone to help them. And, if I can charge a few $100s to put your pellet in every few months, I'm going to help you. Yeah. So, it's a big business, and medicine has created this because we haven't taught our clinicians anything about this subject.
Yeah. And I think one of the things I wanted to talk to you about was the menopause care vacuum. And this kind of leads into what are you seeing from that vacuum? And it's prescribers doing things like pellet therapy.
Yeah. So that's one of the things. I see a lot of women coming in on just 20 different supplements. They'll just try anything to try and improve some of their symptoms, get some sleep, whatever it takes. I see a lot of people coming in on Chinese herbs. They have absolutely no idea what they're taking, no clue. I've seen a lot of raised liver enzymes because of that. And I see a lot of patients coming in, like you said, on the trazodone for sleep. I marvel over the fact that you have no problem prescribing a woman trazodone to get to sleep, but a little bit of estradiol or progesterone identical to what's coming out of her ovaries currently and has been since she was born or in utero, that terrifies you. I mean, what an amazing job they've done convincing us of that. I mean, we are truly in a cult type of situation where we can be seeing something and not believe our eyes.
Yeah. And the
So
answer of an SSRI or
oh
trazodone.
yeah. Well, that's the thing. It's the menopause vacuum is a hormone vacuum, right? So menopause is being treated. We are giving women antidepressants, anxiety medications, sleep medications. We're sending them to therapists because they're overwhelmed when they should be overwhelmed because it's the same as not having any thyroid hormone on board. I see women whose blood pressure starts to go up during the menopause transition. They lose control of their sugar. Their A1C is going up, and your liver loses control over lipid metabolism as your estrogen levels drop too. And so they come in on statins and blood pressure medications and diabetes medications. And then as our levels drop and we start to change where we deposit fat, and now we start to deposit it all around our organs and on the middle of us, around our belly, in such a dangerous place. We see women starting to gain weight, and they'll all say, I haven't changed anything. I still go to the gym a few times a week. I still do my walking every day. I get my sleep. I eat as clean as I can, a healthy diet as much as possible. And I just, every time I get on the scales, I'm gaining weight. And that's all hormonal, And if you can catch that at the beginning, you can prevent all of that. It's truly astonishing that we could leave that information out of our medical training.
Yeah. Well, and the herbs, I had a client, we were going through her list of what her symptoms were, what her lifestyle was like, what her nutrition was like, and then we started talking about what she was taking. And I was like, well, I think you're taking some supplements that actually affect the metabolism of hormones. So you're taking a birth control pill, but then you're taking the supplement that's actually affecting the metabolism of the estrogen in your pill, and they're rendering each other useless. So let's scale back from the things that are not regulated, that there are so many supplements that just aren't studied. And I know there are a lot of people out there who really swear by supplements. There are a lot of people who strongly believe in their supplements, and there's a time and place for certain ones, but you also have to understand that there are side effects and risks that you don't know about because they just don't know how they interact with your liver function, your kidney function, other diseases, other medications. And so it's such a complex thing that when you just open up a social media ad and you click on the latest hot flash relief because that's what you think you need, it's very nerve-wracking as a clinician, I'm sure, to see those kind of things.
Yeah. And then you have celebrities who, Drew Barrymore, for instance, who is, pushing and marketing things like that we know don't have any research behind them or proof or evidence, and they're expensive. And, Drew Barrymore is the person who kind of came out and started talking about perimenopause and really opened up that space for women to feel less stigmatized and for it not to be such a taboo topic. And then kind of goes and does that, which was really disappointing. So when you have somebody that you like and trust, and is going through the same thing as you, and they're pushing something like that too, it's extremely confusing for women. It's really confusing.
Yeah. Well, and I also think that there's a time and a place to like something. And there's wonderful moisturizers or, lubricants, things like that you might have tried that have worked for you. But there should also be a caveat of this may not work for you. This may not be best for you. You need to contact a clinician or a local, your healthcare provider. Whenever I talk to someone about a product, I always say, please make sure with your doctor or your pharmacist that it doesn't interact with anything that you're taking or any disease states that you have that they're aware of that I'm not. And celebrities don't have that knowledge to say, I could really hurt people with what I'm suggesting.
Yeah, I know. It's dangerous out there.
Yeah. So it is kind of the Wild West.
It is. It truly is. I think it's a really confusing time for women, especially as they're learning so much on social media from some people. And then, that kind of pushes you down an algorithm. And so you get more and more videos and reels like that. And so it becomes very difficult to tell who's giving you evidence-based, accurate medical information and who is trying to sell you something.
Yeah. Yeah.
Yeah.
So if you were saying something right now to a woman out there looking at things and filtering them through social media or Dr. Google, what would you suggest to them when they're making their choices about how they want to approach their menopause transition?
Hmm. So I would say there was a great article that was released this past year by Dr. James Simon and Dr. Barbara Levy. And it was called, I'm going to get the title wrong, but it was something along the lines of Contemporary Management of Hormone Replacement Treatment. And in that article, they squashed so much into it. It's so interesting. And it is a fabulous piece to have in your armament, to read yourself, to educate yourself, and to bring to your doctor. Now, that article was printed in what's called the Green Journal, which is the Journal for Obstetrics and Gynecology in America. So you would have hoped that the OBGYNs would read that, but in reality, work is so busy, a lot of us, our journals stack up and you don't get to read them. So that is true evidence-based medicine. It brings you through the Women's Health Initiative study and some other studies. It talks about the different types of estrogen, the different types of progestins and progesterone, and the different effects they can have on your body. And it talks about the benefits of hormone treatment and how for most women there aren't any risks. We always talk about risks and benefits. And back to Dr. Louise Newson in England, her thing is, what about the benefits of taking it and the risks of not taking it? And there are women out there who can't take hormone treatment. If you're undergoing breast cancer treatment at the moment, you really, in general, can't be taking hormone treatment at the same time, because a lot of the medication to fight the cancer blocks estrogen receptors and things like that. So there are some women out there who really can't take hormones at the moment. And I realize that all of us talking like this about how the benefits of hormones, how hurtful that is and how upsetting that is. But that does not change the fact that there are very few women out there who can't take hormones, and the benefits are so great. We're talking, and another thing that's so confusing for people is our guidelines here in America, our FDA approval of things and our guidelines by different boards. And, so if you look at the USPSTF guidelines or the American Heart Association for prevention of cardiovascular disease, hormone treatment is not on there. Like, we've known since the 60s and 70s that women who start hormones in perimenopause and menopause, they have a much lower risk of cardiovascular disease. We have tons of information on that, loads of papers. And yet, when they go to make these guidelines, they pull up the WHI study and they base 90% of everything on that, when we already know those were the wrong hormones in the wrong women at the wrong age. Why would you base everything on that? So it's very frustrating that those things like that are so far behind. So we do have loads of evidence to show cardiovascular protection, especially if you start hormones in the first 10 years after your period or before the age of 60. We know you get massive bang for your buck cardiovascular wise. In your 70s and 80s, your body hasn't seen hormones in years. And so you have missed that boat with regards to that massive amount of protection of your blood vessels and your heart. But you can still reap other benefits, and you still might have some cardiovascular benefit, but that just hasn't really been measured. Even in the WHI study, the women between 60 and 70, there was a null risk, null benefit. Like, the same amount of women had heart attacks and strokes who were on hormones as didn't have hormones. And then over 70, there was a slight increased risk of heart attack and stroke over that first year. And then your risk went back to normal. And that was on horse estrogen, medroxyprogesterone acetate, which is a different type of progestin than we use now and activates all sorts of receptors like cortisol receptors and things you don't want activated. So that's how safe the hormones were, using the wrong hormones. And now we use hormones that are identical to what's coming out of your ovaries today. So safe.
Yeah.
And yet they have managed to make us so terrified of them.
Well, and that's, I still, even my dear friends, I'm like beating my head against a wall sometimes, because there's this mentality that if I'm telling you hormones are safe, you should look into hormone therapy. Then I'm pushing hormones. Like I'm pushing this
Yes.
on you.
Yes.
I'm a hormone pusher. And the over medicalization of menopause, that's been a phrase that has come out.
Oh,
And
yes.
it's like, if you're telling me that, we're over medicalizing high cholesterol or over medicalizing diabetes by giving medications to help with, glucose and insulin, it boggles the mind how menopause seems to be such a hot topic right now, and so crazy in the aspect that you have this camp that's very anti-hormone, and then they're saying anybody who talks about hormone therapy being a safe option is over medicalizing, and you're a hormone pusher.
Absolutely. And I think if you talk to any of us hormone pushers and asked us what was our reason for talking about hormones, I think we'd all say the same thing, that this information has been withheld from women and from pharmacists and clinicians for over 20 years now. And that is enough. Women need to be educated, clinicians need to be educated. And then when you have that information, then you can make a good decision about your health. And your decision might be, I'm never starting hormones. Perfect. But that's based on good evidence-based information. You know what you're talking about. You're not saying I'm never going on hormones because of some, pretty much a Fox News soundbite from 20 years ago saying that HRT causes breast cancer. That's not a good reason to make a decision about your future healthcare. And so, yeah, I don't know how you counteract those people. There's some angry people out there.
There are.
Yeah.
And I think I have had women come to me and say, I'm not really suffering from symptoms. My blood work is all good. My cholesterol is good. My heart rate is good. My blood pressure is good. I work out at the gym. I don't have any signs of osteopenia or osteoporosis. So I'm choosing not to take hormones. If you have an educated understanding that they aren't going to harm you, and you go that route, that's one thing. But I feel like the fear mongering is still so prevalent for a lot of women our generation. I'm hoping as we move forward, the younger ones behind us won't have the same fear around it, for sure. So when we talk about finding a clinician that is someone who's educated and understands how to care for menopause, a lot of women are saying that they don't have a doctor in their area or anyone that they feel comfortable to come to. So telehealth has become, especially after COVID, telehealth became a very prominent way to manage a healthcare practice in cases like menopause care. So how did you get into telehealth practice? What does your telehealth practice look like, in case anybody is interested because they just don't have anyone local?
Yeah. So I work with Dr. Heather Hirsch, who is based over on the East Coast. And she had her own private telemedicine practice and then decided to expand. And 10 of us joined her. And we formed the Heather Hirsch MD Collaborative. And so I see patients via telemedicine in Connecticut, Oregon, and Washington. And it's all telemedicine, and our appointments are, because we work outside the insurance system, our appointments are not 10 or 15 minutes long. The first appointment is 1 hour long. Heather has made an amazing masterclass course, which you can do in your own time, listening to it as you drive or whatever, you're going for your walk in the afternoon. And it starts at the beginning and it leads you through the history of hormones and the benefits and all the information you would need to know to come into your appointment really well equipped to have an in-depth discussion for an hour and figure things out for you. We also have a wonderful Facebook community that patients can join where they get a lot of support. I'm in there, I moderate it and answer questions. And we have events that we host every 2 weeks, different things, journaling, yoga, psychologists, some interesting and sometimes just educational talks from some of the clinicians. And then you get, we do an hour-long appointment. It gets quite detailed, and we really dig in deep and figure out what's the best thing for you. And some women are just looking for information. Like, they're coming early. They know maybe they've started to go into perimenopause, but everything's going okay. But they want just evidence-based information, and they're not really sure where to get that, but they know they'll get it at the collaborative. And other women come because they've been to 20 other doctors first, and other women come because they've seen one of us on a podcast, for instance. And so we get a different groups of women who turn up. And then you get to portal message your clinician in between appointments as well. And so that first appointment is an hour, and then the follow-ups are usually 30 minutes. And our patients just absolutely love it. You can tell from the testimonials and reviews that they leave us afterwards. They leave very, very happy. They leave feeling heard and understood. They leave full of evidence-based information. They feel empowered. And it's been lovely working in the club. Very proud of what we're doing.
I think women who are looking for menopause care, especially, there is something to be said about stepping outside of the traditional healthcare system, the traditional insurance system, and having that ability to have that 1 hour appointment and having those 30-minute follow-ups. You and I were discussing before we started recording that, traditional insurance billing and private practices can't run on hour-long appointments. They just can't. And so if you're looking for a physician or care provider to really dig into what's going on, understand your personal circumstance, because menopause is, again, so unique. Each person is going to have a different experience. And so I think we need to kind of step back and say, okay, yes, I can't bill my insurance for this, but it's worth that cost because I'm getting such specialized care. I'm getting someone who really understands what's going on in my body and is going to help me tenfold. I mean, if you think about all the other frustrating avenues that women could go down, this is going to save time and money in the long run if they think about it.
What I find here in Portland is a lot of people will go to a chiropractor or a naturopath, and everything will be tried except kind of what you would normally do for perimenopause and menopause. And so they are spending thousands of dollars a month on appointments and supplements, all different kind of tests like saliva tests and urine tests that have to be repeated every few months and give you a lot of information, most of which is not very helpful. And so I often see those patients who've just spent thousands and thousands of dollars trying to get some answers. And so they leave us feeling really delighted.
Wonderful. So if there's one thing that you could wish for the future of menopause, for the next generation, for our daughters coming up, what is that one thing that you would say you hope to see for that next generation?
Okay, if I had a magic wand, I would redesign medical school, nursing school, nurse practitioner, midwifery, everything to focus so much on these neuroendocrine hormones that we have that are made very much by the ovary, and make that a massive part of the training. It's so important whether you're on your psychiatry rotation, you're on your rheumatology rotation, cardiology, it doesn't matter. You're going to see people coming in with women coming in with palpitations from their perimenopause. So no matter what organ system you're talking about, perimenopause has an effect on that. And so it has to be an integral part of the training right from the get-go. So that's what I would do. I would train all healthcare practitioners.
Let's hope. I'm crossing my fingers and my toes.
Me too. Fingers, toes, and eyes all crossed.
Oh, goodness. Well, it's been such a delight talking with you. And I think we could continue going on. I love listening to what your experiences have been and what your stance is on menopause care. I could listen to you forever. Not to mention you have it's just so much. Such a delightful voice. I always feel like I'm like shouting but I'm like, no, you're so not soothing. I could just listen to her forever. So thank
soothing
you so much.
/boring.
Oh, no. It was wonderful. And I think there are so many women out there who could benefit from what we've just discussed. I'll put in the show notes the name of the article that you were talking about in case anyone wants to dig into that.
Yes, if anyone's looking for it, Victoria, just go to my Instagram page
Okay.
and my link tree, and it's in there.
Okay, wonderful.
You can open it and read it and print it.
Okay, wonderful. I'll leave that in my show notes as well. And if anybody needs to get in touch with you, they'll find you on social media. They'll find you under Heather Hirsch Collaborative, and I'll share all that in the show notes as well.
Thanks so much. It's been fun.
Yeah, it's been so much fun. I love doing this. It's selfishly like my own personal conversations with people. So.
Thanks so much for joining me today. We'll be back next week for another episode of Women Mastering Midlife. Until then, find us on Instagram at Women Mastering Midlife and join my free Facebook community, Women Mastering Midlife, to continue our discussions. If you have any questions that you'd like answered on an Ask Me Anything episode, send your emails to hello@missvictoriaberg.com. This podcast is intended for entertainment, educational, and informational purposes only. Please note the hosts, guests, and experts featured on this podcast are not your personal healthcare providers, life coaches, or advisors. The content should not be considered as professional, personalized medical, psychological, or prescriptive advice. This podcast is not a substitute for consulting your physician, therapist, local pharmacist, or relevant professionals to discuss your specific concerns and situation. The topics discussed should not be used as the sole basis to diagnose or treat any medical condition, make significant life changes, or make important decisions regarding your health otherwise. Women Mastering Midlife is not responsible for any undesired outcomes resulting from actions taken based on the information provided in this podcast. The views and opinions expressed are those of the host and guests only and do not represent any of those other individuals or entities. Always consult with qualified professionals before making significant changes to your health, regimen, lifestyle, or medical plans.